problema ng bansa upang mapagtuunan ng pansin at mabigyan ng solusyon.
We should have specific goals, do research, and make a policy that is fair for everyone.
Walang problema sa pulisiya. Iayos lang ang pagpapatupad.
Bago patubas ang batas, pag-aralan muna gusto ng government.
Two things, clarity and execution. Both, you need the communication and monitoring. As simple as that.
Mandato ng Philippine Institute for Development Studies o PIDS na gumawa ng mga pag-aaral at pananaliksik ng mga polisiya at programa ng pamahalaan at magbigay ng rekomendasyon sa mga mambabatas sa pagbabalangkas ng mga polisiyang makakatulong sa ating bansa. Sinusulong ng aming ahensya ang evidence-based policy making upang bigyan diin ang kahalagahan ng polisiya na batay sa datos at policy research na sumusuri sa tunay na kalagayan ng ating mga komunidad. Napakahalaga ng policy research, lalo na sa mga panahong dumadaan sa krisis ang ating bansa.
Kapag polisiya ay pinag-aralan, susulong ang bayan!
In need of references for your research? Do you want a digital library that you can access for free anytime and anywhere? You don't have to look far. SERPI is here for you. SERPI is an online database of socioeconomic materials produced by the Philippine Institute for Development Studies, government agencies, research and academic institutions, and international organizations based in the Philippines. It is the country's first online repository of socioeconomic information, created for policymakers and development practitioners, researchers, educators, and students. To access SERPI, just visit the PIDS website and click the SERPI widget under the Databases tab, or type serp-p.pids.gov.ph. SERPI has a wide variety of materials such as journal articles, books, research papers, working papers, policy notes, audiovisual materials, and more. As of 2022, SERPI has more than 60 partner institutions contributing knowledge resources to the database. SERPI provides a comprehensive coverage of references encompassing 22 research themes: labor and education, gender and development, poverty, technology and innovation, trade and industry, and many more. On the enhanced website of SERPI, you can filter your research by keyword or author, publication type, research theme, or year published, all at the same time. SERPI has more than 7,000 publications and audiovisual materials that you can access and download for free. What are you waiting for? Visit SERPI now. Socioeconomic Research Portal for the Philippines, innovating knowledge exchange and policy research.
So what is PIDS? For over 40 years, the Philippine Institute for Development Studies, or PIDS, has been the country's foremost socioeconomic think tank. It conducts rigorous and objective policy research and analyses that help the government in crafting relevant policies, plans, and programs in support of the country's long-term vision and development goals. PIDS pursues its mandate through three basic programs: research, dissemination, and outreach. Through its research program, PIDS identifies and prioritizes studies, develops proposals, and conducts research on priority areas. The results of these studies are then disseminated through different platforms, publications, online resources, PIDS Corner, seminars, and the Development Policy Research Month, or DPRM, held every September. To shed light on key policy issues, the advice and expertise of the Institute's research fellows are also sought by policymakers, government agencies, private sector, and civil society. Since 1977, PIDS has completed numerous policy studies on a wide range of development topics. This brand of service has then translated to policies and programs that have improved the lives of every Filipino. Philippine Institute for Development Studies, service through policy research.
Dapat po munang alamin or matukoy ang pangunahing problema ng bansa upang mapagtuunan ng pansin at mabigyan ng solusyon.
We should have specific goals, do research, and make a policy that is fair for everyone.
Walang problema sa pulisiya. Iayos lang ang pagpapatupad.
Bago patubas ang batas, pag-aralan mo na gusto ng government.
Two things, clarity and execution. Both, you need the communication and monitoring. As simple as that.
Mandato ng Philippine Institute for Development Studies o PIDS na gumawa ng mga pag-aaral at pananaliksik ng mga pulisiya at programa ng pamahalaan at magbigay ng rekomendasyon sa mga mambabatas sa pagbabalangkas ng mga pulisiyang makakatulong sa ating bansa. Sinusulong ng aming ahensya ang evidence-based policy making upang bigyan diin ang kahalagahan ng pulisiya na batay sa datos at policy research na sumusuri sa tunay na kalagayan ng ating mga komunidad. Napakahalaga ng policy research, lalo na sa mga panahong dumadaan sa krisis ang ating bansa.
Kapag pulisiya ay pinag-aralan, susulong ang bayan.
In need of references for your research? Do you want a digital library that you can access for free anytime and anywhere? You don't have to look far. SERPI is here for you. SERPI is an online database of socioeconomic materials produced by the Philippine Institute for Development Studies. Government agencies, research and academic institutions, and international organizations based in the Philippines. It is the country's first online repository of socioeconomic information, created for policymakers and development practitioners, researchers, educators, and students. To access SERPI, just visit the PIDS website and click the SERPI widget under the Databases tab, or type serp-p.pids.gov.ph. SERPI has a wide variety of materials such as journal articles, books, research papers, working papers, policy notes, audiovisual materials, and more. As of 2022, SERPI has more than 60 partner institutions contributing knowledge resources to the database. SERPI provides a comprehensive coverage of references encompassing 22 research themes: labor and education, gender and development, poverty, technology and innovation, trade and industry, and many more. On the enhanced website of SERPI, you can filter your research by keyword or author, publication type, research theme, or year published, all at the same time. SERPI has more than 7,000 publications and audiovisual materials that you can access and download for free. What are you waiting for? Visit SERPI now. Socioeconomic research portal for the Philippines, innovating knowledge exchange and policy research.
So what is PIDS? For over 40 years, the Philippine Institute for Development Studies, or PIDS, has been the country's foremost socioeconomic think tank. It conducts rigorous and objective policy research and analyses that help the government in crafting relevant policies, plans, and programs in support of the country's long-term vision and development goals. PIDS pursues its mandate through three basic programs: research, dissemination, and outreach. Through its research program, PIDS identifies and prioritizes studies, develops proposals, and conducts research on priority areas. The results of these studies are then disseminated through different platforms, publications, online resources, PIDS Corner, seminars, and the Development Policy Research Month, or DPRM, held every September. To shed light on key policy issues, the advice and expertise of the Institute's research fellows are also sought by policymakers, government agencies, private sector, and civil society. Since 1977, PIDS has completed numerous policy studies on a wide range of development topics. This brand of service has then translated to policies and programs that have improved the lives of every Filipino. Philippine Institute for Development Studies, service through policy research.
Welcome to the PIDS webinar series. Before we start our virtual event, we have some reminders. For attendees, your microphone is automatically muted upon entry. If you wish to join the discussion, click the Q&A icon, type your question, and click send. For Facebook viewers, you may send your question using the comment section. Remember to keep your questions concise and direct to the point. We will screen all questions to ensure that they are relevant to the webinar topic and the presentation. The moderator will read the questions during the open forum and cover as many as possible depending on the available time. This webinar is being recorded and live streamed on the PIDS and SERPI Facebook pages. The recording will also be made publicly available on the PIDS YouTube channel. Thank you for joining us, and we look forward to your active participation.
Okay. Good morning, everyone, and welcome to today's webinar entitled Towards Universal Healthcare, Understanding Healthcare Use and Spending in the Philippines. I'm Sonny Domingo, and I will be your host and moderator for today's event. Today, we present a comprehensive study aimed at enhancing the National Health Expenditure Survey of the DOH. This initiative will help us understand healthcare utilization expenditure patterns in the Philippines, aligning with our efforts towards achieving universal healthcare. We will delve into the first two parts of the study, focusing on the analysis of data from the 2018 NHES, to explore Filipino healthcare usage and the financial burden of non-communicable diseases. Join us as we uncover valuable insights that can shape the future of health policy in the country. Before we begin, we invite you to actively engage in today's discussions. Feel free to ask questions, share your thoughts and insights, and interact with our panelists through the Q&A box, via Zoom, or the comment section via Facebook Live. So to formally start our program, let us welcome the PIDS President, Dr. Aniceto Orbeta Jr., to give his opening remarks. Dr. Orbeta, please.
Good morning to all participants here on Zoom and those watching via the PIDS and SERPI Facebook pages. Welcome to our public webinar toward universal healthcare, understanding healthcare use and spending in the Philippines. Before we start, I would like to greet the following STEAM officials. Philippine Children's Medical Center Executive Director Sonia Gonzalez, Professional Regulation Commission Board Member Melinda Garcia, Action for Economic Reforms President Jessica Cantos, ASEAN Society Philippines President Alma Jimenez, Dansalan College Foundation President Fidelina Tawagon, Healthy Futures Global Executive Director Niels Volker, Philippine National Volunteer Service Coordinating Agency Chief Administrative Officer Rodi Carlos. I would also like to greet the various representatives from the government, academia, private sector, civil society, and media virtually present today. Like many countries, the Philippines has prioritized achieving universal healthcare coverage, or UHC. The UHC law, signed in 2019, ushered in significant reforms under the Department of Health and the Philippine Health Insurance Corporation. These reforms included introducing a primary care-focused benefit package, the Konsultasyon Sulit sa Tama package in 2020 to address healthcare financing disparities. Despite the government efforts to expand healthcare access, many Filipinos continue to face the burden of catastrophic health costs, pushing them deeper into poverty. This issue is particularly relevant as the Philippines transitions from a population burdened predominantly by infectious diseases to one increasingly affected by non-communicable diseases, or NCDs. A 2021 study by PIDS revealed significant challenges in tackling NCDs, including lack of primary care facilities and an uneven distribution of healthcare personnel. Compounding these challenges, the Philippines spends significantly less per capita on primary healthcare than other ASEAN nations, restricting resources available for NCDs. Further complicating the situation is the responsibility for delivering healthcare, which falls on local governments. Their varying capacities result in inconsistencies in the quality and availability of NCD care across different regions. Recent data from the Philippine Statistics Authority highlight a concerning trend. While government and compulsory health insurance contribute significantly to healthcare financing, household out-of-pocket payments remain alarmingly high at nearly 45%. Therefore, the full implementation of UHC is crucial. The government must exert greater effort to lower out-of-pocket payments, and lawmakers must prioritize this to alleviate the financial burden on Filipino families. Additionally, UHC reforms must encourage provincial governments to take a more responsibility, promoting local integration and reducing reliance on national funds. Within UHC reforms, strengthening primary care and the role of usual care providers is critical. It is in this context that today we feature PIDS study, analysis of the National Health Expenditure Survey Round 1 and design of survey protocol for NHES Round 2, Phase 1 by PIDS consultant Aida Marie Pantig, Lovely Antolin, and Sally Javier, and PIDS Senior Research Fellow Valerie Gilbert Ulep. The study aims to improve the National Health Expenditure Survey conducted by DOH to understand healthcare use and spending in the Philippines, ultimately supporting the country's progress towards UHC. Today's webinar focuses on first two parts of the study. The first part, trends in healthcare service use among Filipinos with usual care providers, will be presented by Ms. Pantig. And the second part, determinants of household out-of-pocket expenditures on non-communicable diseases, will be presented by Ms. Tulen. Former UP School of Economics professor and University of San Carlos Office of Population Studies visiting research fellow Alejandro Hirin and PhilHealth Fund Management Sector Senior Vice President Renato Limsiaco Jr. are joining us to provide valuable insights. Let us all actively participate in discussing following the presentation. Thank you for being here today and enriching the discussions of this important topic. I will now give the floor back to our moderator.
Thank you very much, Dr. Orbeta. So before we go into our presentations, it's our tradition, PIDS, to do a quick poll before we go to the more serious part of the webinar. Okay, so for today's poll, we have this question. How well do you think the Philippines is progressing towards achieving universal healthcare, or UHC? Very poor, poorly, neutral, well, or very well? So again, how well do you think the Philippines is progressing towards achieving UHC? Very poor, poorly, neutral, well, very well. For those joining us via Zoom, kindly click the link in our chat box. For those joining via Facebook, also click the link provided in the comment section. So a few seconds for you to answer before we go to the results. Right now, we have more than 200 participants joining us via the online platform Zoom and Facebook Live. Okay. So before I show the graph of the results, again, the question is, how well do you think the Philippines is progressing towards achieving universal healthcare? Very poor, poorly, neutral, well, and very well. So now let's look at the poll results. A lot of you have answered that our progress is poor. Our progress towards achieving UHC is poor. So we have a lot of room for improvement, given your perspective. I guess the presentations today and the comments of our discussants will shed more light into issues concerning this drive towards universal healthcare in the country. So we are featuring two parts of a PIDS study aimed at enhancing National Health Expenditure Survey, or NHES, conducted by the Department of Health, titled Analysis of the National Health Expenditure Survey, Round 1, and Design of Survey Protocol for NHES Round 2. It is composed of three parts, two of which will be presented this morning. So the first part, Trends in Healthcare Service Use Among Filipinos with Usual Care Providers, is authored by PIDS consultant Ms. Ida Marie Pantig and PIDS Senior Research Fellow Valerie Gilbert Ulep. It explores the factors influencing usual care provision and how it impacts healthcare utilization across outpatient care, hospital admissions, and emergency room visits, especially in the context of the UHC law in the Philippines. We are very honored this morning to have with us Ms. Ida as our presenter for the first part of the study. Let me introduce our speaker. Ms. Ida Marie Pantig is experienced in health research and has recently contributed to the development of primary care and inpatient benefit packages for PhilHealth. She has also worked with various development institutions to support universal healthcare reforms in the country. She was a former research associate at PIDS, and she holds a master's degree in economics from Waseda University in Japan. Thank you for joining us today. Ms. Ida, you may take the virtual floor.
Thank you, Sir Sunny. Good morning, everybody. So, if I may ask, share screen. Thank you. So, good morning, everybody. So, I'll be presenting the first part of this three-part study, actually, but we'll be focusing on the first two parts of the report. So, the first part is on the trends in outpatient service use among Filipinos with usual care providers. As mentioned, this is an analysis of the National Health Expenditure Survey Round 1, which was done in 2018. So if you notice this, the results of this study are actually from pre-UHC time. And then even in 2018, the direction really was towards a primary care forward health system. And since then, I believe there has been a lot of significant updates and reforms in terms of UHC and primary care, which we hope to discuss later together with our discussants, SVP Renette and Dr. Alex Herin. So next slide, please. Okay, so we start with the context. The guiding principles and policies of the UHC law are in line with the primary health care approach, where WHO defines primary health care as having the information and resources one needs to take care of your health and those you love. So with the UHC law, its key features actually include having an integrated and comprehensive approach to ensure that all Filipinos are health literate, provided with healthy living conditions, and are protected from hazards and risks that could affect their health. And another feature of the UHC law is that it should be able to provide Filipinos the access to a comprehensive set of quality and cost-effective health services across the continuum of care. So when we talk of the continuum of care, that includes promotive, preventive, curative, rehabilitative, and palliative health services, of course, without causing financial hardship. So that's the primary healthcare approach. And then when we say primary care is within primary health care. And the UHC law defines primary care as the initial contact, which is accessible, continuous, comprehensive, and coordinated care that is accessible at the time of need. So that also includes a range of services for all presenting conditions, and also the ability to coordinate referrals to other healthcare providers in the healthcare delivery system. So when we talk of primary care, it is important to note that we're just not catering to the sick. So this serves the entire population, both the healthy and the ill. Primary care system or the primary care provider also serves as the gatekeeper. And when we look at the literature, primary care is also more cost-effective than hospital care. Let's look at the context of primary care financing in the country. So there is not really any information that is specific to primary care financing, but when you look at the spending for preventive care, this is at 11.5% of total health expenditure in 2022. This has already increased, actually. So from 2015 to 2019, this has been below 10%, and we're gradually seeing an increase in the share of preventive care in terms of the total health expenditure. Consulta, I believe most of you have heard of Consulta benefit package. The Consulta benefit payment is only at 0.3% of the total PhilHealth benefit expenses in 2023. And this has already been increasing since 2020. So I'm happy that SVP Renette will be joining us later to provide updates on the Consulta benefit package. Next slide, please. So again, primary healthcare, there isn't really an established primary care system in the Philippines. And prior to UHC, some Filipinos may have identified with a usual healthcare provider, right? So based on literature, those with usual care providers, they actually have increased odds of receiving preventive care or screening services. And also, they're very strongly correlated with earlier receipt of preventive services. So that's not something that we usually see in here in the country because I think our healthcare system is still very hospital centric and curative. We're pretty much focused on curative services. So therefore, the effect of having a usual care provider on preventive services is of importance, particularly in low resource settings such as the Philippines. Next slide, please. So given that background, given that context, the research question is, how does having a usual care provider affect healthcare service use in the Philippines? The objective specifically is to examine the differences in outpatient care use among those with and without a usual care provider. Specifically, the study aims to analyze health service use trends in outpatient care services, to explore the determinants of having a usual care provider, and lastly, to examine whether having a usual care provider affects outpatient care use, inpatient admissions, and emergency room visits. So as mentioned, this is based on the National Health Expenditure Survey done in 2018. It's a nationally representative survey covering healthcare utilization and financing. And for the analysis, we did the descriptive analysis for the trends in outpatient service use, and we made use of a binary response model for measures of association for the last two objectives of the study on the determinants of having a usual care provider. Next, please. We we also define some of the terms used for this study. A usual care provider is a particular doctor's office or clinic, health center, or other place that the household member goes to when sick or needs advice about his or her health. So it's not limited to a doctor. And in terms of outpatient services, the following are identified as the outpatient services in the survey. So that's general checkup, immunization, vaccination, pregnancy-related outpatient visits for diagnosis and treatment, follow-up checkup post-treatment, and the follow-up checkup post-surgery. So next. So we go straight to the results. First, we look at the trends in health service use. Again, this is focused on outpatient services. So we have here a chart divided into three parts. So the first part, it looks at the share of households that utilized outpatient services according to their social demographic profiles. So we're looking at households as the unit of analysis. And then the green section of the chart looks at utilization of outpatient services among those who identified having a usual health provider. And the blue part of the chart looks at the share of households that utilized outpatient services for households that do not have a usual health provider. So given that, we see that around 42% of households utilize some form of outpatient care in the past 6 months. This is more for households in urban areas, households with PhilHealth member, the richer households, and among those with household heads with more education. So we don't have that in the chart, but that's also what the study found. So in general, we see that more households utilized outpatient care among those with usual care provider. That's around 50% of those households compared to those without. One limitation of this study is that we're looking at the household as a unit of analysis. So if there's any one member of the household that sought outpatient care, count natin siya. So that's one limitation of the study. Because if you compare this with the demographic and health survey, I think we're seeing it around 7-8% only. So those figures are not very comparable. Next slide, please. When we look at the type of outpatient service availed by the households, again, we identify the different outpatient services. So majority would visit an outpatient facility for general checkup and for immunization and vaccination. And then we tried to look at the distinction between what kind of facilities they visit. So there isn't really much difference. Let's say for general checkup, 39% of the 79% would go to a public facility, and then 40% would go to a private facility. Except for immunization and vaccination, where we see that majority would visit a public facility for that. Next slide, please. And then when we look at the average distance and travel time to the facility visited by households, on average, the average distance between home and the facility is around 8.7 kilometers. And the travel time is around 41 minutes. This is one way. And we see that the nearest facilities are again for immunization visits, and the farthest are for follow-ups post surgery. Next slide, please. So for this one, we're trying to identify what are the predictors of having a usual care provider. Sino-sino sila na nag-identify na ako, meron akong pwedeng puntahan if I'm sick or I need a health consult. So we want to profile those. And here what we did is we looked at measures of association to identify the determinants. So the study finds that the determinants are actually urbanity, age, older females, household heads, education and age, level of insurance coverage, and wealth quintile. So there's a table on the right. So if you look at the odds ratio column, if it's less than 1, it means they're less likely to have a usual care provider. And if it's more than 1, then they're more likely to have a usual care provider. So what we find here is that urban dwellers have almost 20% lower odds of having a usual healthcare provider compared to their rural counterparts. So holding all other variables fixed. So that's one finding. And I think another significant finding we have here is that for the Pantawid member, there isn't really any significant finding. So hindi ganun ka-relevant if you're a Pantawid member or not, if on having a usual care provider. And let's go one by one maybe. So for age, that's also less than 1. So the younger you are, the higher odds of having a usual care provider. If you're an older female, higher odds. If your household head's education, the higher it is, the higher the odds of having a usual care provider. The same for wealth quintile. And also if we go to the health insurance coverage, we see that if you're a sponsored member or an indigent, you have lower odds of identifying a usual care provider compared to a PhilHealth paying PhilHealth paying member, sorry. And if you don't have an insurance coverage, you have lower odds of identifying with a usual care provider. So that next slide, please. So for this one, if you then identify with the usual healthcare provider, what is the likelihood that you will be availing of services? So the first row looks at those with the usual health provider and how that affects the different dependent variables we have identified at the top row. So that's having an outpatient visit specific for checkups. The third is an outpatient visit specific for treatment and diagnosis. The fourth is an inpatient admission. And the fifth is an emergency room visit. So what we see is that those with usual care providers are more likely to have visited an outpatient facility compared to those without, but not for treatment and diagnosis. That is kind of expected. But I think another limitation of this study is that we don't really know what kind of specific services they are availing. So is it because they are sick, or are they visiting a health facility for counseling, or for some for maybe some rehabilitation or something? That's something that we cannot really answer given this survey data set. But what we find interesting again is that inpatient admission is also more likely for those with usual care providers than those with compared to those without. And same for ER visits. So if you recall in the first part of this presentation, if you have a primary care provider or if you associate with the usual care provider, it is expected that you have better preventive service, more preventive care services, and therefore hopefully decreasing the likelihood of an inpatient admission or an ER visit, which is actually less cost effective in terms of having of looking at the resources for health. So that's something that we don't really see here. So if you have a usual care provider, then you're more likely to be admitted and or also more likely to visit an emergency room. Again, these are measures of association. We're not looking at causality here, but hopefully these are insights that we can dig deeper when we have more data in the future. So next slide, please. So to summarize, what we see is that more among those with usual healthcare providers sought care compared to those without. So it sort of implies a positive health-seeking behavior among the population. If you have a doctor or a clinic that you can visit anytime for consultation or for medical advice, then that's something good, right, for the population. But also, can this also be less cost efficient because we don't really know, maybe patients could be seeking care from specialists or from higher level facilities, given the unstructured or underdeveloped primary care system in the country. That's something that the data set cannot really answer, but hopefully in the future with the UHC reforms happening, that's something that we can already address. And then we also find that there's no distinction for preference in either public or private facilities. So maybe we can leverage on integrating all public and private actors in primary care in making sure that the access of the Filipinos for essential health services are available. So that includes public health facilities, the individual healthcare practitioners, polyclinics, community centers, and the diagnostics and labs. And another finding is that there's, for those with no insurance coverage or PhilHealth sponsored program and indigent membership and urban dwellers, they have lower odds of having a usual care provider. So maybe recent efforts could be directed towards these population groups. Next, please. So there's also, well, there's positive marginal effect of having a usual care provider on outpatient visits. There's none for treatment and diagnosis. And maybe improving this could help unburden the hospital system with the management of illnesses that could instead be done at home. So parang shifting yung treatment and management from hospital setting to an outpatient setting could be done, could be looked into. Also, there's positive marginal effect of having a usual care provider on inpatient admission and ER visits. And these are worth exploring. So as mentioned, maybe there's lack of an established primary care system and the gatekeeping function that is essential in this kind of controlling who goes to hospitals and who goes to ER. Again, just to reiterate, the main limitation of this study is the data quality. So we don't really have that level of disaggregation. And it's also not explicitly stated that the usual care provider is a primary care provider. So we should be interpreting these results with caution. And lastly, next slide, please. So again, there are still differences in access to care, which affects not just health outcomes, but the use of the health resources for hospital and other services as well. But eventually, with the full implementation of the Consulta Plus SDGs, and the comprehensive outpatient benefit package, we do anticipate to see improvements in primary care and its eventual effect in reducing unnecessary hospital admissions and emergency room visits. So as Filipinos associate with the usual care provider, or in this case, a primary care provider, we are hopeful that we will see a shift in the management of certain chronic diseases from early detection to treatment and management in an outpatient setting. So we know that only around 2% of the population gets hospitalized, but the share of curative care to total health expenditure is actually at 46%. And this gives us room to improve our preventive and primary care services through UHC reform. So also, lastly, since it was also mentioned that this work was really to look at how we can improve the National Health Expenditure Survey, we provide some some recommendations. So maybe we can emphasize on primary care, especially that the UHC law is pretty much focused on primary care benefit packages. If we can also detail the preventive services being availed and identify the different private actors and their specific roles in the health system, plus expanding on the different household characteristics to further look at so we can improve how we can target the different services within the UHC reforms. So this is my last slide. Thank you so much for listening and looking forward to your questions later. Thank you.
All right. Thank you very much, Ms. Ida. We will talk more about your presentation later on as we open the floor for questions from our participants. For our Zoom and Facebook participants, you can post your questions or queries via the chat box and the comment section. So now we move on to our next exciting presentation. The second study is titled Determinants of Household Out-of-Pocket Expenditure on Non-Communicable Diseases. It is also authored by Dr. Ulep, together with PIDS consultant Ms. Lovely Antolin. The work focuses on the financial burden of non-communicable diseases and highlights the dual impact of NCDs on the health and economic well-being of Filipinos. Exploring factors affecting out-of-pocket health expenditure on NCDs, the authors suggest that improved insurance coverage and more accessible healthcare services could help alleviate the burden of healthcare costs related to non-communicable diseases. We are very glad this morning to have with us Ms. Lovely Antolin, one of the authors of the study, to discuss their findings and recommendations. So Ms. Tolin is currently a consultant at the Asian Development Bank. She holds an MA degree in public policy from the National University of Singapore. She previously worked at PIDS as a research specialist. I think right now she is in Greece, so quite early there. Thank you for joining us today. Ms. Lovely, you may take the virtual floor.
Thanks, Sir Sunny, for the kind introduction, and good morning, everyone. So as already mentioned earlier, I'll be presenting the second part of the three-part study, and my presentation will be discussing the determinants of household out-of-pocket expenditure on non-communicable diseases. So similar to the first study, it also exploits data from the 2018 National Health Expenditure Survey. Next slide, please. So before I proceed with the rest of my presentation, let me just give you a brief walkthrough of what I'll discuss today. So first, I'm going to provide a brief introduction on non-communicable diseases in the global and local context, as well as why it is an important area for policy. Second, I will discuss the empirical strategy conducted in this study, which is the two-part model. Third, I will briefly provide a description of the data set that was used, which is the 2018 National Health Expenditure Survey, or NHES in short. Fourth, I will highlight the key results from the econometric analysis. And finally, in the conclusion part, I will discuss the policy implications or recommendations, some study limitations, and provide some suggestions for future research. So let's get started. Next slide, please. So as maybe a lot of us know, non-communicable diseases, or NCDs in short, refer to a group of conditions that are not mainly caused by an acute infection, result in long-term health consequences, and often create a need for a long-term treatment and care. In 2015, this group of diseases have increasingly taken a larger share of global mortality, therefore surpassing infectious diseases. So recent data from 2019 shows that NCDs are the leading cause of mortality, being responsible for 71% of all deaths worldwide, or basically around 41 million people per year. The Philippines is no exception, with 7 out of 10 deaths and liabilities classified as NCDs, as exemplified in the chart that you can see in your screen right now. So NCDs such as cardiovascular diseases, cancer, diabetes have climbed in terms of their ranking in the top causes of disability and death from 1990 to 2019. So next slide, please. So the adverse impacts of NCDs extends not only on health, but also on economic well-being. So at the household level, NCDs incurs large financial burden due to direct medical and non-medical costs, coupled with indirect costs from loss of income for patients and caregivers. On an aggregate scale, estimates from the Philippine Statistics Authority show that NCDs accounted for 30% of total health expenditures in 2019, as you can see from the figure on the left. This is a particular concern given that household out-of-pocket expenditures will constitute to almost half of total health expenditures, owing to the lengthy and expensive treatment processes for NCDs, which you can see from the right figure. Within NCDs, cardiovascular diseases and cancer are among those which incur the highest total health expenditures based on the average from 2014 to 2019. So next slide, please. So just to provide like a solid aim for the study or like research objectives, health systems must ensure that people are protected from the financial consequences of receiving medical care. One of the objectives of the Universal Healthcare Law of 2019 is to provide a comprehensive set of cost-effective and preventive health services without causing financial hardship, prioritizing the needs of those who are unable to afford such services. To fulfill this objective, a systematic assessment of health expenditures by type of diseases would rather be important. This will ensure that specific, well-targeted, and sustainable strategies are implemented under the UHC law. So basically, the overall objective of the study was to identify whether and to what extent socioeconomic, demographic, and clinical factors of the population had an impact on out-of-pocket expenditures among Filipinos with non-communicable diseases. So for the rest of the presentation, I'll refer to out-of-pocket expenditures to OOPs. So just, sorry, can you go back to the previous slide? Yes. So there are 3 core objectives that I'd like to highlight. First is to examine the incidence of NCDs among households and their main sources of healthcare financing. Second is to measure the incidence of catastrophic health expenditures in NCDs. And third is to model health expenditure and NCDs as a function of different factors, as I've mentioned earlier. So for the sake of this presentation, I'll focus on objectives 2 and 3. Next slide, please. So before I move on with the model, let me provide just a quick background on the data set that was used. So as mentioned earlier, we used the 2018 National Health Expenditure Survey. So it's basically a household and health provided based data collection mechanism to gather detailed health information. And it has 2 components. One is the household component and the other is the medical provider component. So for this study, the main data set that we use is the household component. And this household component is consist of several submodules. And for this analysis, the submodules that we mainly use are the outpatient and inpatient care utilization and charge payment modules. And the unit of analysis is at the individual level. So we identified NCDs using the international classification, using a variable on the international classification of diseases or ICD-10. And in the study, just to reiterate, we mainly focus on out-of-pocket spending, which pertains to direct outlays among those individuals identified with NCDs. So next slide, please. So let's move on with the estimation strategy that we used. So modeling healthcare expenditure is not straightforward due to its data characteristics. As such, usually health expenditure data is often described to have a significant proportion of zero-cost observations and having a heavily right-skewed distribution for positive cost, with a relatively small proportion of patients incurring very high expenses. And this is true in the case of out-of-pocket spending, which is observed in the NHES data. A sample of the illustration is provided here in the screen for the outpatient care side. So when you take the log of spending, it improves the distribution, and once you impose the logarithm of the OOP spending, it starts to follow a normal distribution and resolves the skewness of the data. So with this type of data, estimation through the usual usual ordinary least squares regression is actually deemed biased. Methodical developments have been made through the years in handling this type of data, and therefore alternatives to the ordinary least squares regression, which is usually commonly used, has emerged. Among the popular estimation methodologies used is the two-part model. So next slide, please. So in the two-part model, the zero values are handled by first modeling for the probability that there are any costs, and second through a conditional regression model for positive costs. So basically, this model accounts for the fact that the excessive zero observations may be generated by a mechanism different from that of positive expenditures or having non-zero expenditures. So compared to just single equation models or OLS regression models, two-part models are actually better at handling the differences or heterogeneity between those who spend and do not spend, as well as the differences based on the level of spending. So in the analysis, the first part employs a logit model, while the second part utilizes a generalized linear model. So in this equation or this model that we are using, the dependent variable represents the out-of-pocket health expenditures among individuals with non-communicable diseases. And we use a set of variables on the right-hand side or independent variables to examine which factors or which determinants are actually important in terms of like determining out-of-pocket expenditures. So next slide, please. Just to provide a summary of the data, just to provide a description of or descriptive statistics of the data that we're using. So basically, the table in the screen presents the summary statistics of the main variables that were used in the analysis. So as you can see, utilization of outpatient and inpatient services tend to vary by the type of location. For outpatient care, individuals with outpatient care visits in the urban areas tend to be higher than those in rural areas. The opposite is true for inpatient services. So for both outpatient and inpatient services, more than half of the individuals are covered by PhilHealth at least, while a very small fraction is covered by other types of health insurance. Public hospitals tend to be utilized the most for both inpatient and outpatient services, followed by private hospitals. And I can see some proportional differences in other variables such as age, sex, and educational attainment, although this tend to be quite minimal. Next slide, please. Just to provide just a quick look at the breakdown of health expenditures based on the NHES. As you can see, expenditure in outpatient and inpatient utilization by service type shows that majority of spending among individuals with NCDs are on medicines, followed by professional care. Most of expenditure are financed from households' own resources, savings, and income, both for outpatient and inpatient services. Next slide, please. So let's move on to the results of the model. So basically, as mentioned earlier, the first part of the model explains the probability of having out-of-pocket spending versus not having one. And this is basically presented in this table using log odds unit. So for outpatient out-of-pocket spending, only expenditure quintile and health facility type were found to be statistically significant. The expenditure quintile variable is associated with an increased likelihood of having out-of-pocket spending by 68% when the individual belongs to quintile 5 relative to quintile 1. Meanwhile, the type of health facility tends to affect the likelihood of having out-of-pocket spending by 2.8 times for private hospital relative to barangay health units. So for inpatient out-of-pocket spending, only several categories within a few variables were found to be significant. Age tends to marginally decrease the probability of having incurred inpatient OOP spending by 1%. Interestingly, private HMO, private insurance coverage tends to increase the probability of having incurred any inpatient out-of-pocket spending by almost 1.9 times relative to having no insurance at all. And lastly, having 2 or more comorbidities also increases the probability of spending by 1.6 times relative to having no comorbidity. Next slide, please. So basically, this plot shows just a visual presentation of the coefficients that were extracted on the second part of the model. So the second part of the model indicates the increase or decrease in out-of-pocket spending, conditional that the individual has any expenditure at all. For outpatient out-of-pocket spending, numerous variables were found to be statistically significant. Say, for example, travel time to the health facility is found to be highly significant, and it tends to increase out-of-pocket spending for NCDs by 17%. The presence of one comorbidity also leads to tends to be associated to an increase in expenditure by almost 28%, relative to having no comorbidity. So for inpatient out-of-pocket OOP spending, being female tends to decrease spending by 36%, albeit the significance level is quite low. Similarly, belonging to quintile 5 or the richest quintile also increases spending substantially as compared to quintile 1. The presence of one comorbidity is associated with a decrease in spending, while having 2 or more comorbidities or diseases leads to higher spending relative to having no comorbidities. Interestingly, it was found that insurance coverage at any type is not statistically significant. Next slide, please. Another noteworthy result is probably the highly significant relationship between out-of-pocket spending on NCDs and the type of healthcare facility utilized. So unsurprisingly, private hospitals and clinics incur significantly higher costs than other health facilities. This may be problematic as a high proportion of the population are still reliant on these private facilities. To ameliorate the exorbitant costs, especially for inpatient services, early detection by preventive screenings and early treatment initiation would probably help in decreasing disease progression and thus reduce preventable hospitalizations. Improving the current state of primary healthcare in the Philippines could also aid in this matter. Finally, local government units could also increase reach by contracting out some services to private providers. Next slide, please. Now let's delve on the results in insurance. Based on the analysis, PhilHealth was alone does not seem to be statistically decrease out-of-pocket spending on NCDs, and there may be several possible explanations for this. On the one hand, it may be that the benefit package offered or support value for NCDs were inadequate, which may imply that the insurance was not enough to ensure financial protection. On the other, this result could also indicate a shift in the demand curve. When people, say for example, had access to PhilHealth, cost of services went down, and so their demand for these services could have also increased. Finally, the findings of the study also suggest that accessibility to health facility matters, at least for outpatient OOP spending. This may suggest a need to provide additional services to NCD patients who live farther from the healthcare units, especially those in the rural areas. Telemedicine may be a potential venue for increasing accessibility as well. So before I proceed to the conclusion, let's probably go over quickly to some of the calculations we made on catastrophic health expenditures. So next slide, please. So this catastrophic health expenditures refers to any expenditure for medical treatment that can pose as a threat towards a household's financial ability to maintain its basic needs. So using the NHES dataset, catastrophic health expenditure on NCDs in the study is measured following the definition provided by the World Health Organization. As such, health expenditures is considered catastrophic if the household's out-of-pocket payment for healthcare exceeds 40% of the household's capacity to pay. So note that the calculation is based on the total medical expenditure of a household wherein at least one member is identified to have NCDs. So as what you can see from the chart, the relationship between catastrophic payments among households with NCDs and their socioeconomic status does not seem to be straightforward. Households in quintile 2 and quintile 3 have a lower proportion of households which incurred catastrophic payments relative to quintile 1, which may somehow suggest the regressive nature of NCDs, where the poorest suffer disproportionately. In comparison with households with at least one member with a communicable disease, incidence of catastrophic spending among those with NCDs tend to be higher or more regressive. So next slide, please. Just to conclude, findings from this exercise allows for an enlarged scope of discussion on the determinants of out-of-pocket spending, albeit at a more granular level. The findings of the study suggest that the type of health facility and health insurance, as well as the travel time, matters in out-of-pocket spending on NCDs. Supplementary increase in insurance coverage, improved healthcare services, and greater accessibility to these services could aid in reducing the burden of healthcare costs of non-communicable diseases among Filipinos. Note, however, that this study is also has also some methodological limitations. First, the study only utilizes the national household, the NHES household component, which is actually based on self-reported data. As such, the OOP expenditure on NCDs might be underestimated due to some recall bias. Second, the analysis is grounded on a cross-sectional type of data. In the future, the extended series of the NHES could therefore be exploited to establish causal inference through some quasi-experimental techniques or other techniques that may prove the reliability of the results. The same model from this analysis could also be applied to identify the determinants and expenditure on communicable diseases and consequently compare it with the findings from this study. Concurrently, since the two-part model does not actively identify whether the increase or decrease in the probability of healthcare spending is due to accessibility or in moral hazard, other methods that could explore or control for this addition could be explored also in the future. And with that, I conclude my presentation. Thank you.
Thank you very much, Ms. Lovely. It was quite enlightening. So for both presentations, we have posted the links in the Zoom chat box as well as the comment section of our Facebook page. So we'll again discuss more about this presentation later on as we open the floor for your inputs and comments. So again, you are all invited to post your questions in our Q&A box via Zoom, and of course the comment section via Facebook Live. To further enrich our discussion, we have invited very themed discussants to share their insights as well as their own assessment with regard to subject matter being discussed this morning. Allow me to introduce our first discussant today, Dr. Alejandro Herin. Dr. Herin brings a wealth of experience and diverse background to our discussion. Dr. Herin is currently a visiting research fellow at the University of San Carlos, Office of Population Studies. He retired as a professor of economics at the University of the Philippines School of Economics. He holds a PhD in economics, specializing in the economics of health, nutrition, population, and human resources. With years of professional experience in health and population policy development, monitoring and evaluation of public programs, and local governance for health. Ladies and gentlemen, let us welcome Dr. Alejandro Herin. Dr. Herin, the floor is yours. Please unmute your audio.
Thank you. Good morning. I shall be discussing more general issues, and that's to provide a bigger picture. And I will leave it to SVP Renette to provide the details. Next slide, please. Next slide, please. In this presentation, we discuss what is unique about NHES, what we need to communicate and establish regular stakeholder discussions. What are some of the insights that we can already get from the analysis that have been provided so far, including the analysis that have been presented earlier. And finally, we explore how NHES can contribute to providing and enriching other data sources, particularly the Philippine National Health Accounts. Next slide, please. NHES is an addition to our national data sets. And what is unique about it is that it links individuals and households directly to their healthcare use and healthcare expenditures, as been described by the two presenters earlier. Other data sets like the FIES, the Annual Poverty Indicator Surveys, National Demographic Health Surveys, do have individual data on socioeconomic and demographic characteristics, but they lack other characteristics. Health expenditures, for example, are only at the household level and not at the individual, and we have to estimate it separately. Other data sets contain data on healthcare utilization, but these are not linked to health expenditures and health conditions. So NHES is unique in that sense. And as we shall see later on, it can also provide additional information that can enrich our national health accounts. How did NHES come about? Initial discussion on NHES between DOH and HPDP of the UP School of Economics started around 2017. At the DOH, we have Beverly Ho, who was then the research director of the HPDPB under the directorship of Maylene Bertrand. Actually, Bev is both the initiator and inspiration for the NHES. Of course, being at DOH, such inspiration also carried with it a certain amount of coercion. At the HPDP, that's the UP School of Economics, we have Orville Solon, Carlo Panelo, Carlos Tan Jr., and Siley Javier, who is also one of the authors of the data. Both these groups work on the survey design and the analysis plan in support of health sector reform, more particularly on issues that are likely to be forthcoming in the universal health care. As we know, the Universal Health Care Act was passed in 2019 before the design and implementation of the NHES. Then the Health Policy Plus international organization took over the implementation of the survey and produced initial analytic reports, which we shall show later. The work on further analysis and the design of implementation and the next round of NHES is being, previous slide first. The work on further analysis and design and implementation of the next round of NHES is being continued by PIDS, which we commend and congratulate. In the next slide please. How do we maximize the use of NHES? And we can start by actually talking to each other. The stakeholders of NHES are the policymakers, the users, the producers of the data and the analysis, and occasionally some random bystander, such as myself. And what we need to communicate, in addition to the unique features and technical aspects of the survey, are the results and insights from existing reports and analysis, both from the HP Plus as well as the current reports. We also need to discuss the analytical plan for the further analysis of round 1 and the design and analytical plan for round 2. And finally, we can also begin to explore how the information from NHES, both round 1, round 2, and subsequent rounds, can be used to complement information from other sources, particularly the national health accounts. Next slide, please. The initial analysis and reports using the NHES has been provided by the HP Policy Plus group, in that case headed by Siley Javier, Rebecca Ross, and their associates. And they produce the analytic report as well as 2 policy briefs. One is on outpatient care and the other one is on catastrophic expenditures. The content of the analysis includes the usual characteristics, household characteristics, the health-seeking behavior and utilization, healthcare charges, health expenditures, financial protection, and this is where catastrophic health expenditures come in, and quality of healthcare and patient experience. It might be noted, well, later on. Next slide, please.
Dr. Herin, you accidentally muted yourself.
Which slide did I go mute?
This slide.
Oh, okay.
The current slide.
Okay. Insights from the PIDS analysis, starting from the report of IDA. One result we get there is that households with usual healthcare provider utilize more outpatient care services compared to those with none. So notwithstanding issues regarding the term usual healthcare provider, which includes a lot of providers, different kinds of providers, and the term outpatient services, which also includes a number of health services. And also the issue of which comes first. You use services and therefore you have a usual healthcare provider, or you have a healthcare provider and therefore you use more services, or are they really determined by a common set of factors? So notwithstanding all of that technical detail, perhaps an interesting question is, what's good about having a usual healthcare provider? We don't really see it there in the regressions, some mention about the literature, but perhaps we can imagine a focus group discussion and find out what we can gather from that discussion. And they will likely identify the following. One is the provider knows your history, especially if they have the electronic medical record system. The usual provider can provide continuous, consistent, and more personal care. And the important part of the continuity of care, which is what is part of the definition of primary care provider, is that it can also lead to patient satisfaction and reduce duplication and utilization of services, and thereby improve health outcomes more efficiently. And they could also add in that imaginary focus group discussion. And this is especially important for chronic conditions such as hypertension and diabetes and other non-communicable diseases. This is in addition, of course, to maternal and child care, which by its nature requires a continuum of services. Now, if it is a good thing, how can we design a delivery and financing system, for example, Consulta, to encourage people to have the usual healthcare provider? We asked the question, what are the barriers to getting everyone a usual healthcare provider in the context of UHC? Now we're talking about primary care provider. There are service capacity issues, doctors, diagnostic facilities, pharmacy services, and the capacity building for this, especially at the LGU level, as we have found out, that lags considerably behind the development of payment systems by PhilHealth. Then there are also financing issues. Investments in capacity takes time and resources, and perhaps this is where the DOH grant system, HFEP, and deployment of medical personnel comes into play. But more importantly, from the patient standpoint, disruption in services, for example, the maintenance drugs, due to inadequate financial protection, can have adverse consequences on their health outcomes. Now, in the next slide, please. The second study by Toling on the out-of-pocket expenditures and non-communicable diseases. One result there is that public and private hospitals tend to be used more for outpatient care than RHUs and health centers. One could note here, has this something to do with the wider scope of services in hospitals compared to RHUs and HCs? Hospitals have a more complete diagnostics and pharmacy services and specialist services. Or is this something to do with the perception of high quality, since also private clinics have higher use than RHU and healthcare centers? And the second note is, what is the implication for this with respect to investments in RHU and healthcare centers? Perhaps the focus would be towards increasing the scope of services to include diagnostics and pharmacies and additional staff, as we had mentioned earlier. And as we also mentioned earlier, this takes time. And this has to be looked in the context of an integrated local health systems, as what UHC is mandating, or in the language of PhilHealth, service delivery networks. So it's not just increasing the scope of services, as in what do you call the RHU, super RHUs. We don't need super RHUs in every municipality, but how does that work out together with the hospitals in a integrated local health system? The second result, which is interesting, is that for outpatient services, NCDs, only private MHOs insurance were found to significantly reduce outpatient out-of-pocket spending, although the coverage of PhilHealth is much larger than the MHOs. And one note here is this due to the limited outpatient benefits from PhilHealth, at least historically, relative to the HMOs? The Consulta has been implemented only in 2020. And earlier outpatient benefit package might have not have been widespread. The second note that we can consider is what is the implication of this for the complementation of health and HMO private insurance as mandated by the UHC Act. And on this note, we might also add to consider how do we implement another mandated provision of the UHC Act, the implementation of the supplementary insurance benefit package by PhilHealth. So there are big questions arising from that particular findings. And finally, in the last set of concerns, next slide, please. How can we make use of NHES data to provide more detailed estimates of health expenditures by the PNHA? As we know, the PNHA has shifted its approach to developing health accounts by using the WHO guidelines. And this approach allows us to come up with more disaggregated data on expenditures by healthcare delivery system categories, like by provider, by function, by disease. And a prototype estimates using a disaggregation that includes disaggregation of, let's say, provider with financing agents, require the use of distribution keys to allocate household expenditures into various categories. But PSA has not yet done that, and we can understand because of the difficulty of providing adequate data to make the estimates robust. But perhaps a more detailed data from NHES would allow more refined estimates of these distribution keys that can be an input into the national health accounts. And an example of this prototype, the next slide, please. Example of these NHAs. So you can have the by function. PSA now just reports total expenditures by function, but it doesn't also cross-tabulate it by financing agent. So we can see medical goods, green, out of pocket. We also saw outpatient curative care is green. And the next slide, very briefly, next slide, please. So medical goods, also practically all green. Ambulatory care, which your outpatient comes in, also green. And then finally, the next slide, when we look at it in terms of disease categories, you have, of course, the NCDs. A lot of them are unspecified, of course, but also maternal care, which is interesting because that we thought was highly subsidized with benefit packages. So these are examples of what can be done, and NHES can probably provide additional information to make these allocation keys better. With that, the next slide, please. Thank you, and mabuhay.
Thank you very much, Dr. Hereen. We'll hear more from you in our open forum. So again, we invited another esteemed discussant to shed more light into the results of our two studies. Let's welcome our next speaker, Dr. Renato L. Limsiaco Jr. Dr. Limsiaco holds a Master of Public Administration from the University of Negros Occidental, Recoletos, and a doctorate in management. He is a career executive service eligible, a DAP graduate, and a certified public accountant. He also earned a diploma in strategic finance leadership from the Asian Institute of Management. As a key figure in PhilHealth, he pioneered the Special Health Fund provisions of the UHC Act and led the development of the Consulta program. With 22 years at PhilHealth, he progressed from being an accountant 3 to Chief Finance Officer. He is an active member of the Philippine Institute of Certified Public Accountants, or PICPA, and Association of Government Accountants of the Philippines, or AGAP, and has received extensive training from prestigious institutions locally and outside the country. Dr. Limsiaco, you have the virtual floor.
Thank you so much, Sir Sunny. and good morning, everyone. Can you hear me?
Yes, loud and clear.
Yeah, thank you so much once again. Of course, we are very happy to be invited and be part of this activity to the President of PIDS, Dr. Aniceto Orbeta Jr., and the rest of the PIDS team. Maraming salamat po. Of course, this activity is very critical, very important for us as we are also implementing a research-based policy. And of course, through this activity, not only sharing PhilHealth's activity right now or program and projects, we would like also to learn and get feedback from our stakeholders, very important stakeholders of the program of PhilHealth, and improve the program implementation and the execution of particularly the consulta. Of course, I'll be giving my reaction, comments, and suggestions. Let me thank also our senior research fellow, my good friend Valerie Ulep, and the PIDS consultant for sharing this material, this study. Surely this material, this report will greatly help PhilHealth in improving its policy and its implementation. PhilHealth's mandate, not only under Universal Healthcare Law, but previously under Republic Act 7875, provides health insurance coverage and ensure affordable, acceptable, available healthcare services for all citizens of the Philippines. And of course, we are considered as the health financing agency of the government. And but nevertheless, given that mandate, the question is PhilHealth really on it attaining the mandate given by the Constitution or by the law? And this slide is my very important slide coming from PIDS to keep PhilHealth attuned to what is really happening in terms of health financing. And based on this study, only 0.002% of PhilHealth's disbursement went to primary care. And this study also shows that we have an average claim payment of 100 billion pesos every year. And this study really pushes us to realign our resources and improve the primary care, particularly it is very insignificant. And I would like to inform everyone that year 2021, 2022, and 2023, the benefit payment, when you say benefit payment, this is already benefit disbursements of PhilHealth now, increased already from the usual 100 billion to 113 year 2020 and 119 billion in the year 2023. And I would like to report that's nearly 500 million already spent out for primary care now in the year 2023. And hopefully it will be increased this year and the following years. In the year 2024, particularly the four months of operation, we spent 52 billion pesos. This is through the tremendous push of the President and CEO right now, Emmanuel Ledesma, that we gonna pay our stakeholders, the hospitals, including the primary care, ng mga benefit payment natin so that they can use this money to operation of the hospital as well. We are at PhilHealth also aware of the healthcare financing strategy of the Philippines, and in fact, we observed that in the past several years, there's no year yet that we surpassed the 20% limit. And this is what we are doing right now, working right now to improve this increase in PhilHealth share to the total CHE of the country. And of course, we are also aware that reducing the out-of-pocket expenditures is one of the priority, the major priority actually. And we are aware that year 2028, we need to reach the 28 billion. And PhilHealth also would like to move forward to attain this increase in the total share in the total CHE of 27% in the year 2028. In fact, year 2024, this is one of our indicators, GCG target, starting year 2024. Let me also share with you that your corporation, your PhilHealth, has resources right now to finance the health services of the country, particularly sa ating mga miyembro, no? Inpatient and consulta. And as of December 31, investment stood at nearly 500 billion. Of course, as of March, it went up to 509 billion pesos already. So we have enough resources to cover the health benefits of our members. And again, with this trend of social health insurance contribution to the total CHC, which is downtrend, no? We also, through the leadership of PCO Ledesma and Secretary Ted Herbosa, need to reverse the trend to be impactful to Filipino by expanding and improving the benefit packages. And this is what PhilHealth is doing right now, no? In fact, the 30% increase in benefit packages across the case rates already implemented starting February 14, 2024, and effect already the benefit payout of PhilHealth, no? And of course, one of the important things as strategy of the universal healthcare is the implementation of primary care and consultant benefit packages, because this covers the consultation, the laboratory and medicines, the antibiotics, in the discussion a while ago about NCD, which we considered as major sources of out-of-pocket expenditures. With this underpinnings, the PhilHealth priorities includes number one, the consulta and benefit expansion, more than any other things. And of course, the provider payment mechanism, the way PhilHealth is changing the payment scheme also being implemented right now, no, from reimbursement to prospective payments. Of course, sustainability, digitalization, and good governance, one of the things that we are prioritizing right now. So the universal healthcare is very important, no, for Filipino people. And the number one thing that considered here is the consulta, the primary care. As again, this is a major strategy of PhilHealth, of the government in terms of providing health services. And each individual should be assigned to primary care, not only to the usual healthcare provider, no, but an accredited and certified, licensed later on by the Department of Health, no, primary care providers. And of course, moving towards the part of the healthcare provider network, no, for AC navigation in terms of health needs. As everyone, every Filipino is an immediate eligible member of PhilHealth and can avail of the benefits regardless if they have the premium or not. As I mentioned kanina, strengthening health care, particularly consulta program, is one of the priority of PhilHealth. And in fact, in the year 2024, we allocated 30 billion pesos for the consulta program. And of course, as mentioned a while ago by our presenter, this is the initial contact, and of course, accessibility to the higher needs care nandito rin siya, and very important for the implementation of the universal healthcare. In fact, March 13, 2024, the board approved the increase in capitation from 500 and 750 in the case of private to 1,700 already. So expecting that many private providers will be joining the program in the next few months to come. Of course, this consulta program, aside from the consultation, we increased already the diagnostic from 13 to 15 to include the ultrasound and mammogram, and 21 medicines, including the NCD medications, kasama po siya rito. So in fact, one of the important things here is that dispensing of medicines NCD, one of the indicators in the payment of consulta capitation, no, which is 20% in the total 20% of the total members should be provided with medicines, NCD. And these are the list of medication under this 21, and many of these are considered NCD medication. Why Consulta? It is expecting approximating 45% of the spending ay nandito sa primary care, no? Medical outpatient services and outpatient drugs to reduce the out-of-pocket spending of all Filipinos. And in fact, again, as mentioned, we changed the way PhilHealth gonna pay, no? From reimbursement to prospective payment in the implementation of special fund in the case of the local government unit. So we are implementing that one under sandbox for the 4 LGUs right now. And these are the LGUs. We have the Quezon, we have the South Coast, we have the Baguio City, and we have the Bataan. And we front-loaded 257 billion already. So these are the pictures of the loading of resources. Of course, we would like also to share, no, in the next few days, few months, this race to 30, reaching all Filipinos with affordable care and enhanced services by 2030, and relative also to 30th anniversary as our strategic campaign towards achieving the universal health care, particularly health financing. This tatlong pangako that kasama sa pangakong ito ay ang pagbigay ng serbisyo, konsulta para makakuha ng serbisyo medikal ang ating kapwa Pilipina. So the details of this will be discussed later on. Of course, in my reaction, the use of NHES on OPP determination. It is mentioned a while ago the importance of NHES as OPP indicator is a universal key performance indicator that the Philippines also adopting. And as for uniformity and comparability across the countries, adherence to the worldwide used out-of-pocket formula should be considered. And very important as well, for verification and validation, you may look into the special health fund provision of the Universal Healthcare Law, particularly Section 20 and 21, as PhilHealth fund will be accrued to that special health fund, no? And as nearly 10% of the out-of-pocket expenditures is shared by the LGUs. Aside from the support value, PhilHealth also adopting right now, and in fact, increasing the percentage share to total CHC. In year 2024, our target is 17% from 13.6 in 2021, and aware of the target in the year 2028 of 27% to reduce this out-of-pocket expenditures to 28% in 2018. PhilHealth also mentioning that based on the formula, the out-of-pocket expenditure, no? We wanted also to look into ano ba yung amount of money, how much benefit payment needed to attain this target of 17% in 2024 or 2027. We need to see the details, we need to see the formula, and we need to know further, no, in terms of the computation. Of course, we agree in it to further improve that the usual providers of care of those ng ating mga kasamahan, ng ating kapwa Pilipino. And we need to bring them to the Consulta program, no? As out of 115, only 22.2 million pa lang ang naka-register. And we need to increase our accredited facility, and we need to increase our accredited physician as well, no? As not yet can cover the entire population of the Philippines. Of course, we also take note of the no distinction and preference in public and private. Of course, we are looking that the mixed network model, public or private led, will be prepared by the providers. And on treatment and diagnostic, laboratory and consultation is part of the Consulta services. We need to bring them as well to receive or to avail these services, no? As this is part of the capitation that PhilHealth is paying. And very small pa lang as of this time yung nag-avail of these services. And of course, we need to have the support and active role of private sector, no, particularly in this program, and they can create their own primary care provider network as well. And we are very happy also to report that there are some private sector also visited us, connecting with us, and be part of this PCPN program that we have. Again, there are only few consulta facility na private ngayon. Out of the 2,548, we have 344 pa lang. We also agree on the expansion of the research, no, to cover the primary care, as primary care is important component strategy of the UHC right now, and agree in this finding about the relationship between the out-of-pocket OOP spending and health facility and the travel time, as it will entail cost talaga. And of course, on the finding that PhilHealth as source insurance does not seem to significantly decrease the out-of-pocket spending. And of course, as I mentioned kanina, only year 2023 that PhilHealth released nearly 500 million pesos for primary care, and 257 of that for the PCPN program. And only in 2023 that through the leadership of PCEO Ledesma and chairmanship of Secretary Ted Arbosa, that benefit packages started to increase, no, to improve. And hopefully the year 2024, we gonna increase the spending, no, to nearly 175 billion pesos. I also agree on these findings and the recommendation, the improvement of primary care services and early detection by preventing screening and better access, no. And we again value your recommendation in the improvement of PhilHealth program, especially the consulta. And this platform really help us really improve the services, and we would like to have a separate meeting with the PIDS on this one, as this can again further improve and very quick the program implementation, and we can have an impact to our kapwa Pilipina. With that, through the leadership of PC Ledesma, is saying that PhilHealth is laser focused on delivering the badly needed health financing, as dahil sa PhilHealth, bawat buhay ay mahalaga. Maraming salamat and magandang umaga po sa ating lahat.
Thank you very much, Dr. Lim Shaco. I think we have a very good group of presenters. We have young researchers in the person of Ms. Ida and Ms. Tulit, and I think very seasoned academic and bureaucrats in the person of Dr. Herin and Dr. Lim Shaco. So before we go to our open forum, may I request our presenters to give their responses to the comments of our discussants. May we start with Ms. Ida. Ms. Ida, please, can you share your thoughts on the comments by our discussants? You have the floor,
Thank
please.
you. Thank you, Sir Sunny. First, Sir Alex, thank you so much for your comments. Really, I think the results of the study are more of parang initial insights, and I agree with having that parang imaginary FGD, because in a way that those are some of the expectations din naman po if you have a usual healthcare provider. And actually, I'd also like to recognize that this kind of information, this kind of survey data actually on having a usual healthcare provider, I think baka ngayon lang din po talaga siya nakita, lumabas, right? And although we cannot really associate the usual healthcare provider to the primary care provider, I think it already provides insights on health-seeking behavior and potentially what good can come out of having a usual healthcare provider for every Filipino. And then dun naman po sa comments din po ni SVP Renette, again, this work was based on 2018 data, and we also recognize yung hard work and effort ng PhilHealth on pushing for consulta and the primary care benefit package. So eventually, when we see a round 2 of the NHES, hopefully with the improvements in the data collection, especially with the EMRs that we will be implementing eventually, we do hope to see na malaki na rin yung improvements in terms of Filipinos associating with the primary care provider and then later on associating that with better health outcomes for those who seek care sa primary care providers nila. And also, looking forward din po sa pag-integrate ng public and private providers in the PCPN and the HCPN. That's something na I think medyo challenging pa at the moment, but hopefully with the reforms sa financing sa provider payment mechanisms that we will be implementing, we hope to see that happen in the near future. So yun pa. Thank you, Sir Sam.
Thank you, Ms. Ida. Ms. Lovely, can you share your thoughts on the comments of our discussants?
Thank you po. Actually, it's very helpful for me kasi ako, even for me, meron din akong NCD. So, it's quite relatable yung topic. It's nice to know that meron talagang palang mga programs recently na targeting yung issue on NCD and tries to alleviate yung financial burden, especially for low-income households. I noticed that during dun sa presentation kanina ni Sir Renet, merong specific area about discussing about dispensing of medicines. And I think that's quite an important element in the sense that, say for example, for NCDs, you'll find the majority or a big chunk of the out-of-pocket spending is actually on medicine. So that will be, I think, a big help in terms of addressing the issue. And then on the big questions from Dr. Hirin, sadly, as much as I want to answer it like in definitive terms, yung study that we created is, at least on my end din, is more on associations and not really an impact analysis. I couldn't much say a lot on the mechanisms that controls for quality of care or accessibility. Although I think these are like very important questions if we wanted to actually improve the reach of programs that help alleviate the financial burden for people afflicted with non-communicable diseases. Dun sa second comment pala, with regards to the finding that only private HMO, GSIS, or private insurance has found to have significantly reduced out-of-patient spending. I think this finding, it could be, there are probably two ways on how to explain this. One is that pwedeng kulang talaga yung benefits provided by PhilHealth. The other is probably, in a lighter note, probably, siguro PhilHealth somehow increases accessibility in the sense, so kung people have PhilHealth, they might think na things might be more affordable and then they incur more cost by actually getting treated or getting the services they need. So ayun lang po. But thank you po for the comments and discussion earlier.
Thanks, Lovely. We now open the floor for our participants' questions to both our presenters as well as our discussants. Okay, so first question. This one is from the Food and Drug Administration. And probably Dr. Herin touched on this in his articulated comments. So the question is, how does the quality of usual healthcare providers affect the frequency of health-seeking behavior and the quality of service the recipients receive? If I recall correctly, Dr. Herin mentioned that, well, our patients prefer hospitals compared to our rural health units and health centers. That probably relates to this question. Is Dr. Herin there? And did Dr. Herin go offline?
That is, let me see. Yes,
May I request you to open your camera, Dr. Herin? Okay, thank you.
I don't see myself. Yes, it's kind of dark in here, but that's a good question that we can ask. That's a hypothesis, of course, that certain facilities are considered or perceived to be better quality, not in terms of the capacity and training, but also the kinds of additional services like diagnostics. Are they complete with diagnostics? Are they complete with medication and things like that? And is it one-stop shop? If you go to a hospital, you can get most of it, including specialist care, without going to many other places. And so that could be a measure of quality in terms that you get all the things that are needed or as recommended by your primary health care. But definitely needs a little bit more careful analysis and actually on-site visits as to what they are and what other instruments can we actually provide or use to actually measure quality. Over.
Thank you, Dr. Herin. Would any one of you want to add to his answer? Maybe Lovely. It's Lovely. Can you provide an answer to that question?
As much as I want to, I think it's an area of the study that I'd like to explore further as well in the future rounds of the NHES. Because at least for my study, it's a bit limited to describe the associations between the different factors, but not really the mechanisms that go underground. But maybe Ate Ida can have a bit more insights.
Yeah, I guess, well, intuitively, individuals or households would prefer facilities that are convenient. As mentioned by Dr. Herin, one-stop shops, those that can provide all the required diagnostics as needed by our patients. May they be outpatients or inpatients. Well, probably also related to that would be the actual demand for healthcare. I think in Ms. Ida's presentation earlier, she mapped the ranking of top causes of disabilities and deaths in the country. And you can actually see there a sort of transition in terms of the main causes of disabilities or even deaths, from respiratory infectious diseases to more of a lifestyle related causes, referring specifically to cardiovascular. So infectious versus lifestyle related, are these also somehow affecting healthcare availment among our households? Also given the possible expenses related to such. So you look at out-of-pocket expenses, you look at insurance, you look at field health in terms of possible contribution, payment of hospital expenses wise. So can you provide an answer there? Or insights or some thoughts related to that?
Sir Sunny?
Yes, please.
Speaker on it. Yeah. The way I see that one, our kapwa Pilipino, our resident right now, the beneficiaries of this program, looking forward for an isang HCPN implementation already. HCPN in the sense that we have that primary care and we have that hospital care in one community that will provide them with the primary care services, including the hospitalization if they needed that kind of services. And in fact, with Apex Hospital, if talagang kailangan nila mas mataas na serbisyo pangkalusugan. So this one is not yet in place. What PhilHealth is now experimenting is a PCPN pa lang, primary care pa lang for the four local government units, public pa lang. And expecting that in the next months or years to come, we can have also the private, no? How this private consulta facility in a network will also integrate in the system and eventually progress towards that HCPN. And I think this is our fellow Filipino looking for an assurance that in the event they will need these services, they have this community, they have this network that will provide them with that requirements, no? That as mentioned by my idol, Dr. Alex, na doon na sila magkukuha ng kanilang serbisyo, na hindi na sila maghanap pa sa iba, conveniently on their part and accessible to them. So hopefully that this year 2024 we can start that HCPN testing already, no? As we have the policy that already approved by the board, and hopefully magawa natin siya this year, Sir Sani and the team. Thank you.
Thank you. Thank you for that answer, Dr. Limsiaco. Am I correct, no, in terms of my initial assessment that everything about primary care provision and service, no, that we talk about right now are really hypothetical, no? Particularly number one, you mentioned that through PhilHealth you have Consulta, but budget-wise, it's quite insignificant, no, in terms of what you have and in terms of what has been provided before. I think this was reflected in both your presentation and IDA's. So, if I'm also correct, when talking about primary care and in the context of the bureaucracy or the government service being offered health-wise, it's really Consulta on the part of PhilHealth that we are talking about. Am I correct in terms of manifesting those internal thoughts?
Sir Sani, primary care on the part of PhilHealth, the brand name for health financing is Consulta. So in other words, the program of PhilHealth in terms of buying that services to our providers is Consulta program tayo. And we have these resources already available. We have 30 billion as of this year, 2024. 30 billion pesos out of 244 billion allocated for benefit payment in year 2024. But the thing is, there are two things in the equation. We are the buyer of the services and the provider. The question is how ready our provider is, how ready our local government unit to take on the services, and of course including the private sector and providing the services, no? And we are again ready to pay these services now. But of course we are changing the way we are paying right now, and even contracting our healthcare facilities from a tingi-tingi or individual engagement to a network contracting already. And again, we are testing this model with Bataan, as Dr. Hiren also aware of this thing because kasama ko siya, and developing this this program, no, the PCP and the primary care provider network contracting. And we observe from the four local government units na ito that talagang tremendous or impact in terms of service delivery makikita natin. The registration, the first patient encounter, the provision of services, na. And in the next few days we will be releasing for the second tranche of their capitation already. So on our part, it is our idea, and of course to address this availability of resources on the part of the provider, yun ang ini-ensure namin. And we can also provide the support, no, in terms of the provision of primary care.
Okay. So if I get you correctly, primary care service provision right now in the context of Consulta through PhilHealth is poised to take off this year with the 30 billion budget allocated to Consulta. And I guess that's good, no? If you go back to the presentations of our resource speakers, our authors, they actually recommended primary care augmentation, and that's true for both our co-authors in those two presentations. And even Dr. Harin also touched on this. Probably another question is, it was mentioned earlier that your usual care provider are less efficient in terms of delivering health services. Does it go to show that the primary care provision is efficient compared to your usual healthcare providers? Who can answer this?
I guess I can answer that, Sir Sunny.
Okay, Ida, please. Yeah.
Okay, so for the study, the definition of a usual care provider is not explicitly a primary care provider. So it can be a primary care provider. It can also be a specialist. So there is no clear distinction on who the usual care provider is. So it is possible that we are seeing those inefficiencies in the results due to that. So it could be that the usual care provider of the individual is a specialist in a tertiary facility, therefore seeing more inefficiencies. Given that the primary care system in the country is really not that established at the moment. So that's one explanation. But I'd also like to build on or respond to the discussion earlier on the primary care being a hypothetical or a theoretical at the moment. So primary healthcare approach has been in existence, I think, in the 1970s with the WHO Alma-Ata Declaration. So if you go back to the whole discourse on the primary healthcare that started in the 1970s, and a lot of countries have adopted primary healthcare approach.
Including in the Philippines.
In Philippines, it was adopted, but it wasn't really systematic parang hindi rin talaga siya nangyari kasi we don't see the gatekeeping function. We don't usually associate with our primary care providers. So we didn't see that happen. So the primary healthcare approach plus the health financing mechanisms through the consulta, I think that's the strategy of the UHC for the primary care system to take off. So you match the primary care system with financing mechanisms. Sir SVP Renette mentioned yung mga prospective provider payment system, capitation, etc. So these are all in the system, in the consulta benefit package to incentivize the providers and the patients and the population to take part of the primary care. I also mentioned earlier that when we talk about primary care, it's not just the sick people that we're taking care of, right? We want everybody to be part of the health system. We want the healthy people to be part of the health system so that we make sure that we'll be able to monitor them, diba? Kasi that's the more cost-efficient way of looking at the health system. So that's it. Thank you.
So probably we need to have more disaggregated data when talking about usual care providers, because you mentioned that a lot of their provided services actually are classified as primary care services. So primary care do exist in the country, not just tangible in certain aspects, no, but consulta from PhilHealth gives that tangibility. Probably it needs to mature over time, and they are in the right track given the amount of resource they have infused into consulta this year. Okay, may I go to
Sir
Dr.
Sunny?
Her?
Sir Sunny?
Yes, Dr.
Before my idol, Dr. Heren, one of the things also that we need to have that information, no, on disaggregation in terms of area, nasaan sa Pilipinas yung okay na yung programa, what particular area in the country kumbaga na okay na ang ating o reduce ng out-of-pocket expenditures, something like that. that can also guide the program implementers such as PhilHealth in terms of where we're gonna focus our resources and improvement in the system, Sir Sunny. Thank you.
Dr. Dimshako, I think going back to your the earlier numbers presented, no, a lot of PhilHealth's resource goes to inpatient spending or costs. No, I think 90% plus compared to very little in terms of out-of-pocket share from PhilHealth. No, so that probably has to be addressed as well. No, and you mentioned how PhilHealth should allocate its resources to better cater to our supposed clienteles. No.
Yeah, yes, Sir Sunny. But what I'm referring to, what particular area in the country, saang probinsya, saang region natin ilalagay ang pondo. That presentation you made mention a while ago, that's already our guide in terms of resource allocation. Maraming salamat po.
So we don't have an existing assessment, geographical assessment in terms of capacity and need, health provision wise. Is that a big concern right now in terms of the local landscape?
Of course, the information not yet completed in terms of geographical. Of course, the out-of-pocket expenditures is only a figure that we see, no, in a holistic view in terms of the Philippines as compared to the other countries. But in terms of geographical, wala pa ho tayong figure on that.
And that's a big concern given the devolved nature of health services in the country. Okay, so I go now to Dr. Herin. I think we appreciate very much, no, that initial articulation about possibly the academic discourse related to our data sources. Now, you mentioned complementation in terms of NHES with the other data sources. You've also mentioned the key roles played by DOH as well as the UP in terms of persuading our institutional partners as well as having that academic rigor in the survey. And that's very well appreciated. Related to our earlier question, you've also articulated something about the usual healthcare provision, where more outpatient services are being availed. And you mentioned, you questioned whether this is good or not. Does it have that positive and negative aspect in terms of the availment of your usual healthcare providers compared to us looking at primary care providers? And related to this are the barriers, in terms of accessing such healthcare provisions. Dr. Herin, can you share your thoughts?
Well, you properly summarized what I said. There are several things there that probably we need to emphasize. Well, we already mentioned, if having a usual provider is a good thing for various reasons. Some of them are intuitive. It's personalized care, it's continuous care. You know who the provider is. You can approach them anytime and so on. If that is a good thing, because we also see that not everybody has a usual provider. So what we want, if it's a good thing, why don't we have everybody have it? And that is where I begin to look at why that it doesn't happen. Let's take a look at Consulta. One is service capacity. So UHC says assign a provider for each person, but there's not enough doctors that you can assign the population. So the maximum load is one doctor for 20,000 population. You have a municipality with 40,000 people with one doctor. So what do you do with the other 20,000? I think there's one question in the chat. Can they still avail of service? Sure, they can avail of service as they have done in the past. They will not be turned away. But two things can happen. Now, PhilHealth is not going to pay for them. And therefore, somebody has to pick up the tab. Either that is the LGU or the LGU might pass on to the patient as an out-of-pocket expense. Hopefully not. But there's a nice twist to this. LGUs are very sensitive to this. And they think of this as a problem in a different way. my consulta, half of them might be provided, financed through PhilHealth capitation payments, so well and good. But there is the other group of people that exceeds our maximum load, and will not be paid capitation from PhilHealth. But they're going to come anyway. And if we don't provide the same services as what we provide the consulta enrollees, we are going to get into trouble. This is the LGU talking, not the provider. He just comes and provides services. But the mayor is concerned, malilintikan tayo niyan. Sasabihin na hindi tayo nagprovide ng service. So there is that potential problem if you don't have that service capacity intact. So there is this, I think, a very important urgency of improving, fast-tracking that capacity, service capacity improvements. Because in fact, that should have been front-loaded before you design your payment systems. The capacity has been set up so that hindi ka naghahabol na paano natin ma-credit yan? Kulang pa sa diagnostic facilities. Paano natin ma-credit yan? Kulang sa pharmacy. So what LGUs do is mag-contract tayo dun sa yung hospital natin, yung district hospital. So people go to the hospital for their tests and so on. And then that creates a real problem. A real case is you have a RHU, you have enrolled people, they go for consultation kasi malapit, but then kulang sa diagnostics, they're referred to the hospital. So the hospital have diagnostics, they have pharmacists. But the requirement is that person who has been diagnosed has to go back to the RHU for the additional consultation and the prescriptions and so on. But well, nandun na ako sa hospital, nandun na yung results, nandun naman yung doktor, doon na lang ako. So hindi na ako babalik sa RHU. And then you are perpetuating yung bypass simply because the capacity of the RHU, the service capacity, the scope, the range of services available is not complete. And that's a real thing. And then there's the other unintended consequence. Ito namang hospital, meron pala tayong capitation. Dati, binibigay lang yan ni Governor na libre. Pwede pala tayong may 500 per person. Sali na lang tayo sa konsulta. So doon na lang magpa-enroll sa hospital. Di lalong naging hospital-based yung konsulta. That's just one example of the unintended consequences of the service capacity not fully developed, or it's developing in a very slow manner compared to the fast pace that Sir Renet has developed its payment systems.
So it's really the supply side limitation in terms of healthcare. No, and the dynamics between what LGUs can offer through RHUs and health centers, and then your bigger hospitals, no, may they be private or public.
And so, there's another thing that I worry about because we're not there yet. One is that the capitation, of course, as we know, Sir Renet knows, it doesn't really pay full cost. But then we say, well, subsidy na rin yun ng LGU. The problem is they don't know what is the full cost and how much PhilHealth pays and how much are we going to put up and how much can we get from DOH if they're willing. So that uncertainty, kaya nga sabi nila, ay dagdagan na ninyo yung capitation nyo kasi alam namin kulang yan. Pero hindi pa nila alam how much are they gonna put up. So the city government actually began to estimate something like that, and they said it will cost them twice as much to provide for the members themselves, but also they have to service other non-consulta members in this regard. So that is something to watch out. Hindi pa nangyayari, so bantayan natin at we should be ready for the response.
So yeah, I think that's another critical dimension to this discourse. You mentioned capitation, and probably that's another entry point for leakages, no, in terms of institutional grounding of such interventions. Whenever you talk about resource, whenever you talk about financial resources, may it be at the national or subnational levels. You talk about potential for inefficient utilization and eventually leakages. I think another question would be in terms of the out-of-pocket expenditures contributing to welfare issues, particularly those bordering poverty, households that are close to poverty, with such shocks being really catastrophic, in terms of their supposed welfare. How do we further address this concern? You mentioned, well, you presented numbers, analysis in terms of catastrophic spending among our households. But really, if you go deeper, this is the meat of healthcare utilization and spending for most of our households. A lot of them do not avail healthcare services because of monetary concerns, right? And that's not really just true for the poorest households, That's even true for some middle-class families. So how do we look at this, given what we have right now in terms of the bureaucracy? Yeah, PhilHealth, you have. Yes, please, Dr. Herlin.
I have to dominate this one, but I might forget. Alam mo naman yung mga matatanda, baka madaling makakalimot.
Right.
What is this issue about catastrophic? If we look at the catastrophic, a lot of them is really the inpatient care, where the amounts are quite large, even with large benefit payments that PhilHealth already provides. It's quite large. What I'm concerned about is that particular out-of-pocket payments in the outpatient, especially for NCDs. So, for example, Serenet said Consulta provides for medicines and drugs. My question is, and this is important to resolve, how far do we finance the medicines? When the doctor prescribes, he's got to maybe prescribe it for 3 months for hypertension drugs or 3 months for diabetes drugs. What happens after 3 months? Is that continuous? Because maintenance drugs is forever.
Yeah.
How far is the financing
Lifetime.
for that? And the reason for that is any disruption in the consumption of those drugs seriously affect the health of that person. And for me, that is more catastrophic than that catastrophic in inpatient care. Or that is a different problem and a more serious problem, because these are the poor people who cannot afford even, it's a small amount, but it's continuous over time. And PhilHealth, I want to ask Dr. Renet whether the Consulta is willing to go all that way, or how far will it go, and how to communicate this is all we can go, and either DOH, LGU, or patient has to provide for the rest. Over.
Yeah. So that's, well, not talk about catastrophic, in terms of the welfare of individuals and households, and catastrophic in terms of their actual health. And those two are, I think, quite good avenues for additional discourse. And then you mentioned PhilHealth, because PhilHealth plays a big role in the scheme of things, particularly when you're talking about huge spending for NDCs. As you mentioned, if you are hypertensive, if you have high blood sugar, if you have cardio-related diseases, you'll need maintenance. You'll need a lot of health-related expenses addressed. But I think in a couple of the presentations was mentioned that PhilHealth's contribution in terms of individual welfare really is insignificant. I think we need to elaborate more on that. Am I correct in flagging that concern about PhilHealth's significance, in the scheme of things? Dr. Lim Shaco, can you answer this? Particularly right now, we've been contributing a lot, premium-wise. It's really, I think, significant for us to mention something like this, because comparing, for example, the premium for private HMOs, and the amount we've been paying for PhilHealth, you see a lot of discourses in terms of why not just go for the private HMOs rather than contribute to PhilHealth, no? Because in terms of benefits, you get more benefits from the HMOs. Quite easier also for individuals and families to avail such, no? So these are things that I think require a bit of discussion. Maybe Dr. Imshako, can you?
Yes, sir, Sari. Again, we recognize that 13.6% based on the report from PSA relative to the contribution of PhilHealth to the total CHE. And this is the thing that we wanted to improve the numbers. But the question is, what number, what amount of money, as I mentioned in my slide, what amount of money that PhilHealth should need to release, disburse in order for us to somehow has an impact in terms of its contribution to the total CHE. Because right now, year 2021, again, that's 100 billion pesos for 13.6%. And year 2022, we have 130 billion pesos released. That's 13 barely increased than the number, the percentage. In the year 2023, that's 120 billion benefit released by PhilHealth. And again, the question is, and we wanted to know what absolute amount, if we're gonna reach that 27% of the total CHE, what absolute amount of money should PhilHealth disburse, and where we gonna put this one? Because as I mentioned earlier, and based on the study of PIDS, 90% of the money went to hospitalization or to the inpatient care, and very small amount of money intended for primary care or spent for primary care. So the question is, bakit maliit yung primary care? And to look into the program implementation of primary care, year 2000 pa nag-umpisa si PhilHealth in terms of financing sa primary care. Pero again, kagaya ng sinasabi nga, hindi siya nag-take up yung programa, given that again we have two sides of a coin. We have PhilHealth, may pera siya, and we have the provider that delivering the result, the services, and somehow may gaps along the way. Bakit hindi lumabas yung perang ito? And then with Dr. Herin and his team, we're trying to address this thing through the network contracting, this prospective payment mechanism that is part and parcel of the implementation of universal healthcare. Hopefully, with this mechanism and including the inclusion or of the private sector in the table, that they will be providing these services as well, not only for the hospitalization, but isama na nila sa kanilang menu is the primary care. And with the increase in capitation right now, hopefully the numbers of consultant provider and even network contracting will be up this later part of the year 2024, ready for its implementation in the year 2025. So again, nasa testing pa lang yung ating PCPN eh. And dito ho natin makikita ang mga to, and buhos lalabas ang pondo ng PhilHealth to this one. Again, as the fund management sector head of PhilHealth, nasa akin alam po magkano yung pera, and alam natin po yung magpondo dito, and readily available yung pondong ito, and kailangan lang natin ayusin ang mekanismo how to access this money on the part of our provider. And ito po yung focus ni President Ledesma right now, na mailabas yung pondong ito so that we can be hindi siya magiging insignificant si PhilHealth, but magiging kaparte po ng programang ito. In fact, in the last May message of the President Bongbong, he made mention already the 30% increase. That's part of the case package natin, no, inpatient. But consulta is one of the things na binabantayan pati ng Presidente. And hopefully, with this discussion, with this platform of ours right now, many participants dito, we would like to see in the next few days the increase in number of the registration, not only the registration, but including the profiling and the utilization of laboratory and availment of drugs and medicines. The figure right now is not yet, hindi pa siya napipick up, but hopefully with this collaboration, tataas lalaki yung number na ito. Maraming
Okay,
salamat,
okay.
sir.
So with more minds contributing to this knowledge acquisition, I guess we'll answer a lot of your questions. Bottom line, from what you've mentioned, we need more studies related to this. No, you mentioned how much money, where to put the money or the resources, no? Whether our system really is ready right now in terms of also imbibing such resources. No? So those may be related to institutional limitations or capacities, not only individuals, doctors, healthcare providers present in those far-flung communities, for example. So a lot of questions requiring possibly more studies. So we need more Idas and Lovelies doing more studies, no, related to this. I think
Agree.
Ms. Lovely mentioned earlier certain concerns about household characteristics, particularly their relationship in terms of usual care provision. And I think from what I've gathered, you have very interesting relationships here. No, the younger they are, the younger our supposed patients are or individuals are, the lesser they require your usual care provision. More females are prone to using our usual care providers. In terms of wealth, am I correct in saying that the wealthier are able to also access more in terms of usual care provision? And then insurance-wise, the more insurance you have, I think you have less usual care provision among our local population. What's, I think, questionable in terms of intuitiveness is for urban dwellers, they have 20% lower odds in terms of going for usual care provision. Can you elaborate more on that? Because, well, if you are in an urban setting, you have access to, I think, better usual care providers, no? Including the bigger hospitals, the more equipped facilities. Who can answer that? Who can provide? Yes, please.
Before that, I'm sure that Ida can answer that, but I want to go back to, I see a question here in the question and answer box, which is rather interesting. There are other sources of financing to augment out-of-pocket. Should we worry? For example, there are budget allocations for health. There are financial assistance from legislators, financial assistance from LGUs, the mayors and the kagawads. You have national government agencies, PSSO, and so on. Is that an efficient way to raise resources? We are now concerned with a basic principle of risk pooling. We are fragmenting our financing to the extent that they can be inefficient because they reduce risk pooling, basic principle in health insurance. And the other one is it might lead to inequities. Because, like, for example, MAIP, which has become popular, but there are certain LGUs, I don't want to mention names, but they are very good at accessing MAIP because they have a congressman in Congress. They have an administrative system that focuses on helping people using MAIP. But what about those LGUs that do not have that?
Without access.
And so on. Okay. So, meron kang our constituents that so luckily happens to be in a LGU that have all of these resources and so on. They have the same health condition, they have the same needs. But these systems, the fragmented part is making them unequal in terms of their access. So,
Dr. Reed, probably a big question related to that is, well, you mentioned multiple sources of budgets or resources towards healthcare provision or acquisition of services. But a big question is whether the bureaucracy is capable of actually consolidating such resources and administering that big a pie, for
Yeah,
health
well,
services.
that is a political question. If everybody has
That's an institutional
stake,
question
if
required.
everybody has a stake on that source of funds,
Uh-huh.
that's a different question. But as part of the basic principle, a more
In
consolidated
terms of risk pooling,
risk
equitable
pooling,
distribution of resources.
this is the way to go. And so we can argue with that. There's another thing that could be contentious, even probably contentious. I want to raise it here so that everybody goes home with a little bit a sense of anxiety. One is Representative Stella Kimbo just said, bawasan na yung premium ng workers kasi marami namang pera si Sir Lynette. I think that came out in the recent papers. So instead of raising it, even reducing it, because PhilHealth has a lot of money and so on.
And probably will agree.
We can go a little bit further. Why don't we abolish this premium payments from workers?
Stop.
Instead, come up with a basic package that is funded by government tax money. That's one step. And then go into yung supplementary financing na supplementary insurance na sinasabi ng UHC. There you have the premiums, actuarially fair, as Stella Kimbo says. And those who cannot afford it, of course, can be subsidized in the same way. So you have a two-tier thing. I think that this premiums from workers, that is parang a relic of the past, which ILO decided that we take advantage of this. And we did in Medicare 1972. We are now 24.
Probably, Dr.
About going away from that also.
Yeah, probably, Dr. Going even more further, even further, why not abolish PhilHealth and go for private insurance provision or HMOs? Given
that's
I know that Dr. Lipsiaco will be
mas mahirap maghanap ng principles there.
Right now, I think the amount we're paying for private HMOs are comparable when it comes to our premiums, for PhilHealth, or even we are even giving more to PhilHealth compared to our HMO requirement, for a certain year.
Not if you are as old as I am.
Okay,
that's not only very high.
Probably one final answer from Dr. Limsiaco, since we have no remaining time left.
We understood very well that all of us, mga empleyado, paying our contribution, paying our premium, 50% shouldered by the government para sa atin ng mga empleyado ng gobyerno, and the private sector also doing the same. And on the part of the self-employed, they're the one paying their contribution para sa sarili nila. That's the reason why pinapalakas yung konsulta, yung programang ito. But the question is, from among our 5 here in the platform, or even the participants that we have in the webinar, how many % already you registered under sa konsulta? And how many % were able to get that first visit encounter? Because the question of Dr. Herin a while ago, in terms of NCD medication, maintenance drugs, supposed to be this would be shouldered already by the consulta provider, because PhilHealth will gonna pay that 1,700 regardless man kung siya ay kaparte ng NCD medication na nangangailangan or hindi. So on the part of 20,000 sa isang doktor, how many % ay nangangailangan ng NCD? And how many % lang ba ang nangailangan ng antibiotics or even laboratory? But the thing is, we are expecting that that provider will gonna provide that NCD medication throughout the year, whole year ba? So ibig sabihin, the maintenance drugs no longer be the problem of each one of us using the NCD medication, because it will be provided by the consulta provider already, and PhilHealth will gonna pay that one.
So that's also
with this,
hypothetical.
how much money getting from our pocket for the maintenance drugs natin ay laki kaya. Pero kung nakarehistro na tayo and ito yung programang ito ay gumagana na batay sa the intention of the program, talagang mabawasan yung ating problema in terms of health financing
Sustain
personally.
health-related
Because it is
expenses.
already it should be the PhilHealth already that's spending money for this. So ito yung kailangan siguro natin palakasin, paano natin i-ready yung healthcare facilities natin and mga miyembro beneficiaryo that can avail of this one because consulta regardless ka man kung you're paying premium or hindi, Pilipino ka, 115 million dapat ma-restro at saka mabigyan ng
Dapat
serbisyo.
covered. Well, the bigger question is whether PhilHealth through Consulta can actually service that many individuals, no? More than 1 million patients, supposedly requiring sustained spending, for NDCs. So that's
Yes,
another
po.
big question needing to be addressed. And I guess we've run out of time, and probably another venue for this can be set, for us to look more into such discourses, detailing how PhilHealth can be strengthened, how we can strengthen further the implementation of Consulta, how we can cover more our supposed national and subnational clienteles. May they be institutions, households, or individuals requiring health-related services. Ano pa?
Yes.
Okay.
Pero
so
Sir
we've run-
Sunny, very quick lang,
Yeah.
very quick lang. The mission right now hindi on the later part. Ngayon ay papaano natin to bring in them to the Consulta program that they can start the availment of this program. So resources can be found later na siya sa
So I
kung
think-
kailangan na siya natin because national government may pondo naman allocated.
So maybe
para
information dissemination has to be up there in terms
i-strengthen
of
talaga natin po.
priorities, on the part of PhilHealth, because
Yes,
even
po.
us, within the bureaucracy, are not really that aware of programs like Consulta,
Yes, po.
or even the distinction between primary care and usual care provision. So
Yes, po.
a lot of these have to be, I think, made tangible on the part of our supposed stakeholders, which are, of course, the individuals and households availing of healthcare services. Ano pa? Okay, so we've run out of time. And although we have so many more questions to ask, I guess this last portion, before we end our webinar, some of you can actually address those unanswered questions that you've read in our Q&A box. Okay, so before we close, may I request our presenters to actually provide their final thoughts, on the webinar today. May I start with Dr. Imshako? You can continue on with your earlier manifestation, just to close those ideas.
Maraming salamat Sir Sunny, and maraming salamat sa PIDS family for giving us this opportunity to share our programs, programa ng gobyerno, programa po ng para sa kapwa Pilipino natin. The President right now, PCO Emmanuel Ledesma, and of course the Chairperson, Secretary Ted Herbosa, and the team, Department of Health and PhilHealth, working hard to make this Consulta, this primary care, institutionalized. And we allocated a lot of money para po dito. In fact, last year, this is 17 billion but barely hindi nagamit ang pondo. And this would be continuously in increasing the allocation for the primary care, as this one is one of the major strategies of the universal healthcare, that we can have the profile, that we can have the laboratory, that we can have doctors and medicines accessible to each and every Filipino at the primary care level. And that they have the navigators that may sabi natin, may baba natin at mawala yung sinasabi na 60% ng Pilipino namamatay na hindi man lang nakakita ng doktor. This Consulta program, though it is in early stage of its implementation, marami na ho tayong observation na maganda ang nangyayari sa ground. So we have the Bataan, we have the Quezon, we have that Baguio, we have the Sokot for the primary care provider network right now na nag-uumpisa na ng front loading ng pera. Yung pera ang available na po sa kanila because of this front load. And hopefully that we can implement also to the other part of the countries. And not only sa mga local government, including the private sectors, because alam naman na po natin that we cannot scale up all these things without the assistance, without the help of the private sectors, as mentioned in the studies, no, in the study kanina. And PhilHealth po ay will be, again, we have the Race to 30 campaign, strategy campaign already, and we're gonna look into this one and tap the resources, whatever resources we can get from you, particularly research team po ng gobyerno. And to the this is a whole of government approach na kailangan natin eh. And in fact, Doc Alex rin and the team, hindi to nangyayari kung wala sa tulong nila sa development partners. And marami tayong development partners na tumutulong sa atin para mapalaganap at saka mailagay ito sa maayos po. And hopefully, may sabi ng presidente po natin, PBBM, that itong kampanyang ito ay nagawa under his administration, nangyari po na hindi nawala itong milestone legislation po ng universal care. And mapagmayabang po natin sa buong mundo that UHC is working here in the country. Maraming salamat po.
Thank you. Ms. Lovely, your closing statements?
Again, thank you po kasi I think I learned a lot from the discussions as well. Siguro my key takeaway is that we're already somehow in the right step by having a rich data set that allows us for a more detailed analysis. In my part, I think knowing kung ano yung mga determinants that drives high out-of-pocket expenditures so that we could properly target kung ano yung mga dapat na i-prioritize in terms of financing would be good for like policy implementation wise, just to help to lessen the financial burden among households, particularly those with non-communicable diseases, since we see that it's actually regressive in nature. So, ayun, thanks again.
Thank you. Ms. Ida, for your final thoughts.
Thank you, Sir Sunny. I guess I'd like to highlight what Sir Alex mentioned earlier. The importance of the supply side, kasi it is possible that people do not have a usual care provider kasi baka wala naman talaga sila. Also, we weren't able to answer how they identified the usual care provider. Was there a health event that prompted them to seek care? Or maybe there are other reasons. So the supply side is very important. We're happy that PhilHealth has a lot of money to pay for the supply side. But another important question is, how are we going to pay? What are we going to pay for? Kasi if you look at the portion of social health insurance, the total health expenditure, one way of lowering that is by decreasing yung share na out-of-pocket payment, right? So the work really is on improving financial risk protection. Of course, the money from PhilHealth will come in, but choosing the right payment mechanism, provider payment mechanism, it is important to have these demonstrations, these testings to identify kung alin yung pinaka-effective na provider payment mechanism. And aside from the supply side intervention, of course, the demand side, tayong mga Pilipino, makialam din tayo, tingnan natin kung ano yung mga nangyayaring programa ng PhilHealth ngayon, lalo na sa konsulta kasi chance na natin to, lalo na yung mga walang HMO, you get your free laboratories and diagnostics, right? So that's a very good program, but yeah, so demand side, supply side, I think those are two sides that we need to look. Thank you.
To avail the services being offered by the government, particularly by PhilHealth. Right? Okay, so Dr. Herin, your final thoughts, closing statements. You are muted. Please unmute.
Okay. My main message is contained in my slide 4, and that is how do we maximize the use of this information, the analysis that have been presented so far, and what other analysis that have been done before that. And as I mentioned there, we need to start talking to each other. That is principally looking at the insights beyond what the regression models provide us. Insights into policy and program implementation, particularly red flags or unintended consequences of what are usually good intentions and so on. But we need to be prepared, broaden the insights, not only from the results of this study, but supplementary study, even imaginary discussion groups, and so on, so that the discussion will be enriched. I see a lot of questions in the question box, and they are quite insightful as well, and we hope we can go over them at some point in time. I simply took advantage of the last one that about this pooling of resources, the fragmented nature of how we raise resources and so on. But there are others there that perhaps PIDS can collate, and maybe we can help respond to them. Over.
Yeah, we'll send you the unanswered questions so that you can manifest your knowledge and insights related to those. Okay, so we've come to the end of our webinar this morning. Thank you very much to our amazing panel for the valuable insights, and of course to you, our audience, for the active participation and the rich discussions. Let's give ourselves a big round of virtual applause. So before we officially close the program, let me announce the raffle winners. For those joining our event for the first time, PIDS selects 2 winners from Zoom and 1 winner from Facebook as a token of gratitude to our attendees. So our winners from Zoom are number 1, Rochelle Floron from the Food and Drug Administration. And our second winner from Zoom is Mr. Anthony Rosendo Faraon from Swedic Family Foundation.
Oh.
From Facebook, we have Mr. Cedric Bagtas from the National Trade Union Center of the Philippines. So again, congratulations to our 3 winners this morning. PIDS will be in touch to give you your respective prizes. Once again, we appreciate your attendance today. The speakers' presentations will be available at the PIDS website, flashed on the screen. Meanwhile, you may download a copy of the studies from the link provided in the Zoom chat box, as well as the comment section of our Facebook. So, as usual, please help us improve our webinars by answering our feedback form through the link provided in the Zoom chat box, as well as the comment section of Facebook. Please note that the e-certificate of participation will be automatically generated once you submit the completed feedback forms. So complete the feedback forms and get your respective e-certificates of participation. Your feedback and recommendations will make our upcoming events even more insightful and better. Keep in touch. Follow us through Facebook, Twitter, or X, and YouTube channel for more updates. Also, feel free to visit our website for more information. We have been posting the results of our researches both in our official website as well as in another platform, SERPI. So go to the PIDS website and avail of all those very rich information. We hope to have you again, of course, in our future events. Join us in another PIDS event next week, May 22, featuring 2 studies on labor inclusivity and labor mobility in the Philippines, as well as in the ASEAN region. Same time, 9 o'clock to 11:30 a.m. That's May 22 next week. Please visit, of course, our website /events to know the details of other upcoming events, not only for this month, but for the coming months. Finally, we'd like to extend our gratitude to our participants from the government, academe, CSOs, international development organizations, and private sector for joining us today. We hope you've gained valuable insights from today's discussions. It is clear that the Philippines is making significant strides toward universal healthcare, or UHC. Let us craft a future where every Filipino has access to quality healthcare. And with that, thank you again, everyone, and have a pleasant day ahead.